Good evening, everybody. My name is Dr. Amala Nasrat, and I am a specialist obstetrician and gynecologist with Prime Healthcare Group. I thank the Emirates Medical Association wholeheartedly for asking me to be a part of this process, and I thank our chairperson for a generous introduction. I would like to initiate this talk by telling you that I will be speaking about the pathophysiology of VTE, which is vascular thromboembolism in pregnancy. At the outset, I would like to mention that I have absolutely no conflict of interest associated with this talk or this session. Carl Sagan has once said that something, somewhere, incredible is waiting to be known. And this forms the basis of every scientist who is trying to look for answers for several questions posed to them. And one such scientist who has done incredible amount of work in terms of vascular medicine has been none other than the acclaimed German scientist called Rudolf Virchow, who was a 19th century Berlin scientist and a physician, and is credited with the recognition of several factors, and because of his extensive work, we have been now using these factors for the treatment of vascular thromboembolism. Another important, I will digress a bit, but another acknowledgement that we associate Virchow with is the presence of Virchow nodes, which are the right supraclavicular nodes, which are palpable in advanced gastric carcinoma. So his body of work has been extremely crucial and helpful in us managing and diagnosing and treating vascular thromboembolism. Before we start anything, it is always better to go to the basics of of the subject to try to understand what the subject pathology is, how to treat it, and how to make the patient's life better by understanding the basics. So the basics of any thromboembolism or any pathophysiology behind thromboembolism lies with three factors which are postulated by Virchow. They're called as Virchow's triad. These factors, Virchow's triad consists of these three factors that may predispose the person to development of venous thrombosis. These factors include hypercoagulability, stasis, and endothelial injury. Through this presentation, I am going to make you aware how a normal, uncomplicated, no morbid condition attached pregnancy actually promotes all of these three factors, and that's why the incidences of VTE and pulmonary embolism arise during pregnancy. So we go to the first factor, which is hypercoagulable state. Understand the fact that normal pregnancy is a hypercoagulable state, and a hypercoagulable state, if does not exist previously before pregnancy, is initiated by pregnancy. This is the most important risk factor contributing to thrombosis during pregnancy. What contributes to hypercoagulable state? When pregnancy happens or occurs in a woman's body, fibrin generation is increased, fibrinolactic activity is decreased, the levels of coagulation factors like 2, 7, 8, and 10 are all increased. And there is a progressive fall in protein S levels and acquired resistance to activated protein C level. All these changes reflect the physiological preparation of hemostatic challenge of delivery. This next aspect of pathogenesis of thrombosis is venostasis. As we all know, venostasis does tend to occur to all women who are pregnant. Venostasis occurs due to hormonally induced decrease in venous tone, especially in the veins of the lower limbs, and obstruction of venous return due to the enlarging uterus. There are studies that clearly prove that approximately 50% reduction occurs in the venous return starting from 25 to 29 weeks of gestation and lasts up to 6 weeks postpartum, after which the venous return or the venous velocities return back to normal. The third potential corner, or the third potential aspect that promotes vascular thromboembolism, is endothelial damage. Endothelial damage can occur at any time during pregnancy or during delivery or from venous hypertension. It is a very common fact that pelvic vein thrombosis, although rare outside of pregnancy, accounts for up to 6 to 11% of deep vein thrombosis and VTE during pregnancy and puerperium. So we have all of these factors, but it's very rare for us in our everyday practice to encounter patients who are absolutely not associated with any comorbidities. And why so? To understand the maternal mortality in BAME population, which all of us fall under, which is black race, Asians, and minority ethnic communities like the Arab communities, which most of us belong to, we all fall into the category of BAME. In order to understand the increasing rates of maternal mortality in BAME race, the EMBRACE report extensively studied from 2013 up until 2016 the incidences of maternal mortality in women belonging to BAME category. And according to this report, although in general the prevalence of VTE is about 4 to 16 in 1,000 pregnancies, and about 30% cases of VTE present with pulmonary embolism, the incidences of VTE in BAME population, which at least 70 to 80% of all of us and our patients coming to us fall under this category. In this category, the incidences of VTE increases by 5-fold in the third trimester and by 16-fold in the postpartum period. And on top of that, BAME population are at an increased risk of VTE, both due to congenital and due to acquired factors. Now, congenitally, it has been postulated that population belonging to BAME ethnicity tend to have a congenital weakness in the tunica media of their blood vessels. As it is when compared to an artery, the tunica media of the vein is very, very thin. If there is a congenital abnormality in the tunica media of the vein, it is difficult for this particular vein, when dilated or when as varicose, to come back to its original shape and size after a pregnancy. And that's why this population, or this category of population, are more predisposed to vascular thromboembolism. In fact, according to the UK EMBRACE report, the first and the leading cause of maternal mortality in this category of ethnicity is vascular thromboembolism. So it is very important for us to focus on this particular topic and understand what causes it. While I have mentioned briefly about the congenital factors, there are certain acquired factors which we see in everyday practice that should run a red flag when it comes to managing these patients. These factors, acquired factors, are broadly classified into major factors, intermediate factors, and minor factors. I shall present them now. The most important major high-risk factor is any previous episode of vascular thromboembolism, either in the previous pregnancy or because of any underlying condition or situation. If the patient gives any risk, any episode of taking treatment for VTE, or if she's currently undergoing treatment for VTE, that should be a big red flag. The intermediate risk factors, which include previous history of VTE, which is related to a major surgery, high-risk thrombophilia present without any episode of vascular thromboembolism, medical comorbidities that exist with the patient, where previous history of cancer or current history of treatment of cancer is going on, if there is associated cardiac failure, active systemic lupus erythematosus, inflammatory bowel disease, nephrotic syndrome, type 1 diabetes, and sickle cell disease. These come under intermediate risk. Then, of course, you have surgical procedures where the patient undergoes surgical procedures in the second trimester, like appendectomies. And most important, in this upcoming age, although the incidences of OHSs have grossly reduced because the fertility guidelines say to use antagonist instead of an agonistic cycle, but OHSS in the first trimester also carries an intermediate risk of developing vascular thromboembolism. The low-risk category is the category that most of us come across with patients who have at least one or two or maybe even three of these low-risk factors. Obesity is a growing, I would say, epidemic in this part of the world, and majority of the patients that come to us have a BMI of above 30. They do come under low-risk factors. If the age is above 35, because as we are aging, constantly atherogenesis is taking place. Atherosclerotic plaques are being formed in our blood vessels due to lifestyle or due to a sedentary lifestyle or eating habits which are not proper or regular. As we grow older, atherosclerosis incidences increase. Plus, if the patient belongs to the BAME race category, then the chances of atherosclerosis are even much more. So age of the patient above 35, if the parity is more than or equal to 3, which is that every pregnancy, if you have pelvic vein and lower limb varicosities, they tend to get progressively worse with every subsequent pregnancies. So if we have a patient with a parity of more than 3, they come under low risk factors. If there are gross varicose veins seen in the patient, that's why examinations of the limbs are very important in pregnant patients to see if there is any varicosity. If there is current preeclampsia, if the patient is immobile, for example, paraplegia or etc., if the patient has a first-degree relative with an estrogen-provoked or unprovoked vascular thromboembolism, if the patient has a low-risk thrombophilia, and or if the patient has multiple pregnancy, either induced by ovulation induction or spontaneous conception, or if the patient has undergone IVF or artificial reproductive techniques. Last but not the least, most important category that we do tend to ignore sometimes or miss, but is also a part of a low risk factor, is patients coming to us with severe hyperemesis gravidarum. In patients with severe hyperemesis gravidarum, right from the first trimester itself, there is metabolic disturbances that takes place in their system. There is a lot of fluid loss because of hyperemesis, and because patient is not able to keep any in, it is recommended for these patients that if they have major or severe hyperemesis gravidarum, and if they have their weight loss more than 15% of their pre-pregnancy weight loss, it is important that these patients to be considered for administration of or treatment of VTE. Now, management or approach to a patient of VTE, as my esteemed professors and teachers, Professor Salima Wani and Professor Bashir Taha, will emphasize that management of a patient of vascular thromboembolism must always be a multidisciplinary approach. So you have to involve your hematologist, probably your endocrinologist, if required, your immunologist, in order to handle a case of vascular thromboembolism. It has to be a multidisciplinary approach. This is just roughly a small, brief slide, which, of course, my esteemed professors, both Dr. Salima Wani and Dr. Bashir Taha, are going to emphasize on. But this is a small snippet from Green Top Guidelines, which are Royal College Guidelines number 37A, which tells us how to manage a patient with antenatal assessments on the treatment. Understand the treatment of vascular thromboembolism is only heparin. Whether it can be low molecular weight heparin, whether it can be fractionated heparin, or if it could be an anticoagulant like warfarin, the decision has to be taken by the physicians and by the endocrinologist handling the patient. So in our case, if we get a patient with minor risk factors and not any major risk factors, what do we do? This is just a small, brief assessment. Details shall be discussed by both esteemed professors of this session. But it says that any previous VTE, except a single event related to major surgery, comes under high risk and requires treatment with low molecular weight heparins. Now, low molecular weight heparins are available in this part of the world in different forms. We have enoxaparin, deltaparin, and tinzaparin. We use in In our practice, we use either tinzaparin or we use enoxaparin. So we use a prophylactic dose of enoxaparin to be 40 milligrams and of tinzaparin to be 3,500 international units. These patients require antenatal prophylaxis right from 12 weeks onwards with in high-risk category. When you have patients with intermediate risk category, you have to consider antenatal prophylaxis with low molecular weight heparin, depending upon how severe are the comorbidities. Ideally, it is advised to be started from 12 weeks up until 6 weeks postpartum. But this is the category that is most important that we face in everyday practice, where, as I mentioned before, if there is obesity, age, excessive parity, the patient is a smoker or shisha smoker, if she has gross varicose veins, current preeclampsia, any form of immobility, any family history of VTE, low-risk thrombophilia, has multiple pregnancies, IVF, ARTs, and of course hyperemesis gravidarum, weigh the risk and pros and cons of the patient, take a detailed history. If you have 4 or more risk factors, then prophylaxis has to be started from the end of the first trimester, which is from 12 weeks of gestation right up until 6 weeks postpartum. If there are 3 risk factors, then the prophylaxis has to be started from 28 weeks onwards. And if there are fewer than 3 risk factors, then it's completely lower risk. Early mobilization is the key, but do not forget that most important thing that helps these patients is compression stockings. So TED stockings also has a major significant important role in giving supportive support to the lower limb veins, especially of the left leg. The next slide is, of course, the postnatal management is once the patient is delivered, how do we manage the patient? The American College of Obstetrics and Gynecology labels the postnatal management as actually the 4th trimester, and it is rightfully so, because the patient is still under your care up until 6 weeks post-delivery. And majority of the VTEs and pulmonary embolisms present to us during immediate postnatal period. So it's important to monitor these patients. So for high-risk patients, it is recommended that at least 6 weeks of postnatal prophylactic low molecular weight heparin therapy should be given. And these high-risk patients are, of course, as mentioned before, any previous VTE, any high-risk patients who've been taking antenatal low molecular weight heparin should continue into 6 weeks postpartum. If there is high-risk thrombophilia, if there is low-risk thrombophilia, okay, these should be continued towards 6 weeks postnatal prophylactic low molecular weight heparin. Patients who fall under intermediate risk, such as if there has been cesarean section on full dilatation or emergency cesarean section in labor or elective cesarean section, or if the patient has a BMI of more than 40, if the patient has had readmission or prolonged admission in the puerperium, if there is any surgical procedure in the puerperium except immediate repair of the perineum, and if there are associated comorbidities as discussed before, in intermediate risk category, at least 10 days postnatal prophylactic low molecular weight heparin should be given. But if persisting or more than 3 risk factors are present in these patients, then we can consider them to be under high risk and continue low molecular weight prophylaxis for at least 6 weeks postpartum. And of course, then we have the minor or the lower risk category patients who we see a lot. we see most of these comorbidities that coexist in the same patient, where the age is above 35, the patient is obese, above 30, parity more than 3, she's a smoker, even a shisha smoker, if there is an elective LSCS, if there's a family history of VTE, thrombophilia, varicose veins, systemic infection, immobility, current preeclampsia, multiple pregnancy, preterm delivery, stillbirth in the current pregnancy, mid-cavity or rotational forceps delivery, or any kind of operative delivery, or if there is prolonged labor more than 24 hours, or if she's had a PPH of more than 1 liter, or if she has required any kind of blood transfusion because of atonic PPH, then if 2 or more risk factors are present, you must give her 10 days of postnatal prophylactic low molecular weight heparins. But if there are fewer than 2 factors, it is important to early mobilize this patient. Please also educate the patient regarding calf compress exercises. And of course, TED stockings play a major role in managing these patients postnatally. So these are my references for the talk, and I would just like to end this particular talk by quoting Alice Walker, and she says that thank you is the best prayer that anyone could say. I just say that one a lot. So I thank you to express my extreme gratitude and humility and understanding of the subject, and I wish you well. Please stay safe, happy, healthy. Thank you.
Thank you very much, Dr. Amala. Sorry for joining late for some disconnection problems. Thank you for everybody, all audience, for joining us this second webinar of Emirates OB/GYN Association Society. This is the second webinar, venous thromboembolism, and Dr. Amala went throughout the guidelines and VTE risk assessment and pregnancy, antenatal and postnatal. Thank you very much, Dr. Amala, and thank you, Sanofi, for sponsoring the event, the webinar. We would like to introduce our second speaker today will be Dr. I want to announce for the Dr. Bashir. He is the chief of obstetric medicine department at Corniche Hospital, and I think everybody knows Dr. Bashir with long experience in obstetric medicine, high-risk patients, dealing with all medical problems, critical cases of medical comorbidities in pregnancy, whether it is chronic disease in pregnancy or arise acutely in pregnancy. Thank you very much, Dr. Bashir, for joining us for our webinar for tonight. The floor is yours.
Good evening. Assalamu alaikum. I would like to start by thanking the organizers, especially Dr. Mona Tahlak and her colleagues, for giving me this opportunity to participate in this very important symposium. So my talk is today, I'm going to talk about antenatal management of venous thromboembolism. I have got no disclosure, and my objectives will be introduction, assessment of venous thromboembolism, diagnosis, and management. Well, we know that venous thromboembolism is the leading cause of maternal mortality and morbidity in the developed world. Lack of high-level data surrounding thromboprophylaxis in pregnancy is lacking, really. And what is important is prevention. So prevention comes first. Prevention of venous thromboembolism is the most important safety practice in hospital, recognized as a significant international patient safety issue. Venous thromboembolism prevention should be fully integrated into hospital systems and processes. The trigger for the venous thromboembolism prevention is assessment of risk, and I'll elaborate on that later on. Appropriate preventive treatment can be given in line clinical guidance. So we know that venous thromboembolism is 4 to 5 times higher in pregnancy, and it occurs at any time during gestation. More common, as Dr. Wani will tell us, in the postpartum period, mostly on the left side, as we have shown from the previous speaker, and it accounts to 1.1 deaths in 100,000 deliveries. So blood clots can kill. What is the incidence during pregnancy? As I mentioned before, pregnant women are 4 to 5 times more likely to suffer from venous thromboembolism than non-pregnant women of the same age. Reported incidence of VTE is between 0.6 and 2 episodes per 100,000 deliveries. 75 to 80% pregnancy associated with venous thromboembolism is deep venous thrombosis, and 20 to 25% is pulmonary embolism. If deep venous thrombosis is untreated, 15 to 24% of these patients will develop pulmonary embolism. And pulmonary embolism may be fatal in almost 15%. And in 66 of these, deaths occur within 30 minutes. So this is from the confidential inquiry into maternal deaths. And as you can see from these slides, the major direct cause of death is thromboembolism, followed, of course, by indirect causes of death, as we know, is cardiac disease in pregnancy. And distribution of venous thromboembolism in pregnancy and puerperium, as shown in these slides, is throughout the pregnancy, but the most vulnerable period is a postpartum period, and I'm sure Dr. Wani will tell us more about this. So if we talk about the VTE incidence in pregnancy and puerperium, the first trimester is about 10%, second trimester is about 10% as well, and the third trimester is almost 29%, but in the postpartum period account for almost 50%. What are the risk factors for venous thromboembolism in pregnancy? Well, we know that there is increase of clotting factors to prevent the woman from postpartum hemorrhage, decreased fibrinolysis, decreased endogenous anticoagulant, venous status, obesity, age, operative delivery, previous venous thromboembolism, and thrombophilia. But there are forgotten risk factors for venous thromboembolism. Hyperemesis and dehydration. First trimester surgery was a ectopic or ERPC. Ovarian hyperstimulation syndrome, thanks to our IVF colleagues. Blood loss and transfusion. Immobility, inflammation and infection, preeclampsia and nephrotic syndrome. So if we go to risk assessment and see what are the common risks which are not acquired, but there with the woman, for example, age, obesity, parity, smoking, cross varicose vein, current systemic infection, immobility more than 3 days, long flight or more than 4 hours within the last 2 weeks, dehydration, hyperemesis, ovarian hyperstimulation, and hypertension. So any 3 factors of these will put the woman into immediate risk. And this one you consider thrombophylaxis from 28 weeks of pregnancy. But if she has less than 3 factors, so she is categorized as low risk, and probably mobilization and hydration is enough to protect her from any venous thromboembolism. But what about single high-risk factor? So single previous VTE with no family of history of thrombophilia. Thrombophilia, but no venous thromboembolism. Significant medical comorbidities like heart or lung or kidney disease, SLE, cancer, inflammatory condition, and sickle cell. this please is consider antenatal thromboprophylaxis with low molecular weight heparin or offer referral to combined obstetric hematology clinic for advice. But the single high risk factor is a previous venous thrombosis with no thrombophilia. This will recommend antenatal thromboprophylaxis with low molecular weight from early pregnancy. Previous venous thromboembolism or venous thromboembolism in first degree relative or recurrent venous thromboembolism. This is recommended also to give thromboprophylaxis, and you can seek advice from our combined medical obstetric hematology clinic, just like the one we run every month in our hospital. This is a chart which shows the risk assessment as recommended by COG and the factors I've mentioned you before. So I think this should be on each of the consultation rooms in any antenatal clinic. So previous VTE, low molecular weight from early pregnancy. If you have 4 risk factors, as I mentioned before, 3 or more, so low molecular weight throughout. 3 risk factors, low molecular weight from 28 weeks. Admission, low molecular weight to be given unless there is contraindication. For example, bleeding. In first trimester, ovarian hyperthyroidism syndrome, low molecular weight throughout the first trimester. IVF pregnancy, low molecular weight if there are 3 other risk factors. Hyperemesis gravidarum, low molecular weight when these patients are admitted to hospital. When do I assess the risk of VTE? All patients that are booking should be assessed for the risk of venous thromboembolism. And please reassess them on admission or if their condition changes. So identify women with reduced mobility for 3 days or more, surgical and patient with trauma, and of course, post-delivery. Assess for the risk of bleeding before offering pharmacological venous thromboembolism prophylaxis. So the key recommendation for all women should undergo an assessment of risk factors for venous thromboembolism in early pregnancy or even before pregnancy. This assessment should be repeated if the woman is admitted to hospital or develop other undercurrent problems and after delivery. I'm sure my previous speaker has told us about the anatomical condition of where we find or look for thromboembolism or deep venous thrombosis. 88% are occurring on the left side versus 55% in non-pregnant women, 71% are proximal versus 9% in non-pregnant women, and 64% were restricted to the iliac or femoral veins. So, how do we diagnose deep venous thrombosis? So, Doppler ultrasound is a modality to check for deep venous thrombosis. What about pulmonary embolism? We start with a chest X-ray, and then we do a big lung scan or CTPA, and I will tell you more about these modalities. Don't use dimers in pregnancy. They are useless unless pregnancy-specific ranges are used. And to my knowledge, there's still, or in very few centers in the world where D-dimers could be used in pregnancy. So what about the problems we face when we make the diagnosis, or we want to make a diagnosis of DVT, or we have the clinical suspicion of DVT? And if the ultrasound is negative, but if you have a high level of suspicion, please start anticoagulation and repeat your ultrasound in day 3 and day 7. But sometimes the prevalence diagnosed BE in pregnant women with suspected BE is 2 to 6%. People are worried about radiation exposure, but if you look at this table, you can see that chest X-ray or perfusion scan or ventilation scan or CTBA, the dose is less than 0.001. Yeah? And the recommended doses in rats is 0.5, in milligrade is 5. So if you can see, that is a thrombus diagnosed by CTBA. So this is showed pulmonary embolism. If we compare venous ventilation perfusion scan versus CTBA, there is increased risk of fatal childhood cancer at the age of 15 following in utero radiation exposure, which is 0.06 per milligram, 1 in 17,000 per milligram. The fetal radiation exposure set to CTBA is 0.01 milligram, with VicoScan is 0.5 milligram. So 10 milligram radiation CTBA to a woman breast increases her lifetime risk of developing breast cancer by 13.6 above her background risk. Where VicoScan investigation of first choice for young women, especially if there is family history of breast cancer or patient has had previous chest CT scan within the last 2 weeks or so. Higher rate of non-diagnostic scan in pregnancy with CTBA is 37.5. Maybe related to the imaging protocol employed, and in VicoScan is only 4%. So if available, if your resources are available, VicoScan is preferred for young women, especially if you are having a woman with a strong family history of CA breast. What is the suggested thromboprophylactic doses for antenatal and postnatal low molecular weight heparin? For enoxaparin, any patient below the 50 kilogram, it is weight related. So any women below the weight of 50, 20 milligram of enoxaparin daily. Between 50 and 90 kilogram is 40 milligram daily, and over 90 to 30, 60 milligram, over 130 to 170 is 80 milligram, and obese woman over 170, 0.5 milligram per kg body weight daily. Hyperprophylactic dose, or what we call intermediate dose for women weighing 50 to 90 is 40 milligram 12 hourly. Treatment dose, as we know, is 1 milligram per kilogram body weight 12 hourly antenatally, and 1.5 milligram kilogram daily postnatal, as Dr. Wani tell us in her following talk. So the treatment with low molecular weight heparin give wide weight for confirmation of diagnosis, high thrombose in current pregnancy or metal-cardiac valve, enoxaparin 1 milligram per kilogram body weight twice daily. Please don't use the dose 1.5 milligram per kilogram daily. This is a non-pregnant dose and should not be treated or used in pregnant women. What about delivery? You stop the low molecular weight at onset of labor and liaise with obstetric anesthesis. Just a word about thrombolysis. There is a systemic review of 29 articles, 189 patients, no maternal deaths, 1.6 major bleeding events in the last series, about 122 patients, 67 other patients, 3 major, 2 minor bleeding events, and 3 fatal deaths. The RCG has produced guidelines for regional anesthesia. The recommendation is to discuss with the senior anesthetist, discuss implication of low molecular weight therapy with women prior to labor delivery, delay 12 hours after previous prophylactic dose, and delay 24 hours after treatment dose or BID dose, and low molecular weight only 4 hours after catheter removal of epidural catheter, or 20 to 12 hours after low molecular weight dose before cannula is removed. And for elective C-section, thrombophylactic dose of low molecular weight day prior to C-section, omit the morning dose of delivery and do that section on that morning, and thrombophylactic dose 3 to 4 hours after catheter removal, and recommends treatment dose in the evening, i.e. after 12 hours and after the hemostasis being secured. There are conditions which you cannot offer thromboprophylaxis: active bleeding, inherited acquired bleeding disorders, concurrent use of anticoagulant like warfarin with INR more than 2, regional anesthesia within the previous 4 hours or expected within the next 12 hours, acute stroke, thrombocytopenia where platelets less than 75, uncontrolled systolic hypertension with blood pressure more than 230 over 120 millimeter of mercury, hypersensitive to heparin or low molecular weight heparins, and history of heparin-induced thrombocytopenia. Also don't offer thromboprophylaxis with low molecular weight heparin if any of the risk factors of bleeding, unless the risk of VTE outweighs the risk of bleeding. Reassess patient risk of bleeding and VTE within 24 hours of admission. And admission for induction of labor, you should omit the low molecular weight heparin, or early labor or established labor, you should omit your dose of low molecular weight heparin. There is no doubt the low molecular weight works. Heparin, the relative reduction risk of VTE is 88%. Assumed previous VTE risk is 10%, and actual risk is only 1.2%. So the risk, the highest days for the risk is 6 weeks to 100 days postpartum. So it is 28-fold increase in the risk of venous thromboembolism or pulmonary embolism. And I'm sure Dr. Wani will give us more or throw more light on this issue. What about the recurrence of venous thromboembolism in pregnancy from different studies when antenatal prophylaxis is not given? So if you can see from these studies, it's about 10% there is a risk of recurrence, especially either in pregnancy or in estrogen-containing contraception pills. So both contribute a high risk for recurrence of VTE. What about the use of low molecular weight in early pregnancy loss? Before 10 weeks of gestation, you have to screen for antiphospholipid syndrome. Pregnancy complication, not to screen for inherited thrombophilia, and for women who fulfill the laboratory criteria for antiphospholipid syndrome and meet the clinical antiphospholipid syndrome criteria, 3 or more pregnancy losses, antepartum prophylactic with low molecular weight heparin with low dose heparin is recommended. I'm not going to talk about the long-term sequelae of DVT because I think Dr. Wan is going to cover this in her talk. And this is one of the things you should be giving to your all junior doctors and probably put it in your antenatal clinics, because this is how you calculate your risk and then accordingly give your thromboprophylaxis. So Bte Prevention Framework, it's you have to identify at risk of patients at risk. You have to assess for VTE risk and document your assessment. Then you prescribe appropriate prophylaxis, engage your patient in the care, and do regular assessment, especially when the woman condition changes from one condition to another, and monitor performance and strive for improvement. So with this, I think I will hand over to Dr. Wani, because do you know that blood clots are more common in the first few weeks after giving birth? Have you asked about your anti-clot injection, and check with your midwife or with your doctor to make sure that you have had yours? I would like to thank Professor Kasim Nilsson Pierce and Dr. Salim Owani for sharing some of their slides with me, and thank you for listening.
Thanks a lot, Dr. Bashir. It was very interesting. You went throughout many important tips while assessing VTE in antenatal and postnatal. Thanks a lot. I just wanted to remind the audience that if you want to ask any question, please press on the question and answer button and then write down your question, whatever question you would like to ask, and the speaker. If you favor any speaker, just add the name of that speaker. Now, coming to the last presentation, Dr. Salima Wani. She will talk to us about the postnatal VTE and its sequel and management. She is the acting deputy chief medical academic affairs department, Cornish Hospital. She is basically obstetricians, but interested in obstetric medicine and especially the VTE. The floor is yours, Dr. Salima.
Good evening. Thank you very much for inviting me for this webinar, which is on venous thrombosis. My subject is a little bit limited to the postnatal part of it. Postnatal venous thromboembolism in pregnancy, into sequelae and management. I'll try not to repeat what has been already spoken, but overlap sometimes is possible because we are talking on the same subject. What's important, we should be keeping eyes open to thrombosis. I think it's a very good quote, and which has been put by the world on World Thrombosis Day, which was on 13th October. And I think more important which is lacking, is to make the people about the awareness. And that is always in the month of March. That is called Clot Awareness Month. I have no disclosure to declare. I will try to cover some introduction and why we need to give postpartum thromboprophylaxis, what is effective management, especially diagnosis and treatment. I'm going to give one slide on the overview of COVID-19 and its implications for thrombosis and anticoagulation, and few take-home messages. And first question which I want to answer is rationale for thromboprophylaxis in postnatal period. As we all know, thromboembolism is the leading cause of direct maternal mortality and morbidity in the world, in the developing part of the world. Of this, postpartum is the highest risk period when thrombosis or thromboembolism can happen, and that's as much as 60-fold higher than before pregnancy. There are so many studies which have looked into pooled incidence in the antepartum and postpartum period. And if you see it, it's about 118 per 100,000 person years. And whereas you go to the postnatal period, it goes up to 424. And if a patient has undergone cesarean section, the risk is double than this. So again, a very, very high risk for thrombosis and thromboembolism. What is bad about not knowing much is that we don't have any consistent decrease in the mortality over the past 20 years, and that has been reported by the Embrace last report. So postpartum VT risk, if we take overall, it's the highest. But what's more important, if you look into the per day risk of thrombosis during postpartum period, it's much higher. It's 15-fold higher than the daily risk in pregnancy. And also it's 15 to 35-fold higher than age-matched non-pregnant controls. It returns back to normal within 6 to 12 weeks after delivery. But what is unfortunate thing that there's not a very robust data surrounding thromboprophylaxis. If we look into the last Embrace report, thromboembolism is the leading direct cause of maternal mortality in the United Kingdom, whereas cardiac disease is the overall indirect cause of maternal mortality in UK. So if we look into the Embrace results, last report, there were 37 deaths due to thromboembolism, and main was pulmonary embolism in 35 patients and CVT in 2. And of them, 20 patients of the 37 were postnatal. And if we look into the cesarean sections and vaginal deliveries, cesarean section were more than the double who had postnatal thromboembolism. Unfortunately, if we remember, the first guideline which was introduced by the RCOG was in 1995, and it was mainly focusing about the post-cesarean section. And what we found with that, there was a dramatic decrease in the number of maternal mortality due to thromboembolism. And then came the second guideline in 2004. There was another further decrease in the guideline, and then in 2015 there were two guidelines published. One was 37A, 37B. But what is unfortunate that there has been found to be a slight continuous rise in the mortality due to thromboembolism in UK in spite of having these guidelines. So what, it's not same in the UK, it's even the same report if you see from the US, same thromboembolism is still the leading cause of maternal mortality. If you go to other parts of the Europe, the same is the problem. One of the reasons which you can think that there has been no persistent decrease in the number of deaths due to thromboembolism could be that there is delayed dosaging of the thromboprophylaxis, or it's a missed doses of thromboprophylaxis, or delays. If there is a patient who has symptoms, there is delayed review, or there is inadequate review of that particular patient who has symptoms, which leads to the outcome. This is one side of the story. What's the other side of the story, which is the population-driven changes? The women are getting now more older, they are more obese, and they have more risk factors, and they also undergo more interventions. And one of the bigger interventions is the IVF. And likely it is that in future we'll see more VT in pregnancy, and it will become a more greater problem. So what we need to pay is an attention towards prevention, and for prevention we need the prenatal assessment or risk assessment of these patients. I think this has been already covered, and this is why pregnancy is a high risk. We know there is hypercoagulability, there is decrease in the amount of natural anticoagulants, there is increased venostasis, and there is a vascular damage, and which is the risk cost triad. There are many studies which have been carried out on to find out why postpartum periods are high-risk periods. There is one meta-analysis which is a little bit older, but very important information that the DVT events during pregnancy were 0.23, but when you go to the postpartum period, the incidence goes to 0.82 per day. And the recent study which was published was in 2010, and that was again showing the same, that there is 5-fold increase in the risk of thromboembolism during pregnancy, but this risk increases 60-fold in the postpartum period and extends up to 3 months. Later on studies, I'll show some more studies which support the same. This is one of the bigger studies as well, and this comes from the Netherlands, and this is a mega study. What again they show that the postpartum period is the highest risk period, and the odds ratio is almost 84. So if we go into, does it make a difference whether it's a DVT or it's a pulmonary embolism or it's a DVT plus pulmonary embolism? If you see all the three parameters or all the three subjects, whether you take DVT alone or P alone or DVT with a P, all you can find that the postpartum period is the high risk, and the odds ratio is 72, 34, or 46. So the conclusion of this mega study was there is increased risk of venous thrombosis during pregnancy, and the postpartum period is especially a high risk period, and it can extend up to 6 weeks postpartum. Does it make any? Then the other study came, which is from the Jacobson, and this is again one of the very best quoted studies still, is what did they look? They looked into more elements into, does preeclampsia make a risk? Does preeclampsia alone or preeclampsia with IUGR make a difference? If a person has a preeclampsia and she has an intrauterine growth restricted baby, the risk of odds ratio goes to 5.8. If she has a high BMI, but at the same time she's immobilized, the risk goes up to 40. So high risk of immobilization and obesity is a very, very high risk as far as the risk of VTE is concerned. Now, one of the problems, again, which we see very common in obstetrics is the bleeding. If we take the postpartum bleeding and surgery together, if patient has a postpartum hemorrhage or it's more than 1,000 mils, the risk is about 4.2 odds ratio. But if she has 1,000 mil blood loss plus surgery, the risk goes up to odds ratio of 12. So extremely high risk factors as well, which need to be considered in the postpartum period. The other ignored factors are postpartum infection, especially a very, very high risk. It can go up to 20-fold higher. Stillbirth is a risk factor for developing preeclampsia, irrespective of any other risk factors. If a patient receives transfusion for any reasons, not only for the postpartum hemorrhage or for anemia, the risk again increases, or if a patient has a lupus, it again increases the risk of having odds ratio for the thrombosis. Does mode of delivery make a difference? Yes. If you see the top line of the graph, you can see that this is what happens with the post-cesarean section. And this is, if you see the 2004, what happened, this was where the introduction of the guidelines took place. And if you see in comparison to the vaginal deliveries, which is the lowest one, and the intermediate line means overall pregnancies and deliveries. The same thing, whether the patient has a cesarean section or a VSD or vaginal delivery, you can see the cesarean section rate is much higher risk of venous thromboembolism in comparison to the patients who have vaginal delivery. So again, the same thing to say, the rate of pulmonary embolism, whether it's mode of delivery, does make a difference, and it's higher in patients who have a cesarean section. So one important message, yes, cesarean section becomes a high risk for postpartum thrombosis. So does it make a difference how long the duration of postpartum risk extends? It is a very good study, again, from the Jacobson to show the same, that the risk is in the first trimester or second trimester, third trimester, it goes higher as the pregnancy advances. But once we go to the postpartum period, half of the people have postpartum thrombosis in comparison to overall pregnancy. What was again quoted in this study was that assisted reproduction and gestational diabetes, again, are the risk factors for developing deep vein thrombosis or thromboembolism. Cesarean section, preeclampsia, very strong postnatal risk factors for the development of deep vein thrombosis. This is another study which was published from the UK, and this is 1 million women were in the age group of 15 to 44. And what they found, again, that the highest risk is the postpartum period compared to antenatal and outside pregnancy. And this is the graph showing the same, that the postpartum period is the highest risk period. And same, if you take per week, the highest week is between second and third week of post-delivery, and can extend up to 3 months. This is another cohort of the studies to see, which was from the Danish study, and they extended the period from 1995 to 2005. And they looked into all the IVF cycles, and of these cycles, which were 18,000, almost 19,000 cycles, and what they found, about 48 cases of VTE. And the conclusion again was that the VTE incidence was significantly increased in cycles, in pregnancies which were after assisted reproduction, especially in the first trimester. And as we all know, the first trimester could be hyperemesis or it could be ovarian hyperstimulation syndrome, and also very high in postpartum period. This again is a graph showing the same thing, that the patients who have now again, what important message is here, the number of the babies, the higher the number of the babies, whether they are twins or triplets, the risk goes much higher in comparison to the singletons, and this is the normal population you can see in comparison. And the same thing is after birth, and if you see postpartum, the risk is extending up to 12 weeks. So again, showing the same, that the risk of IVF cycles of developing postpartum thrombosis is much higher than in the normal cycles, and again, it is more in cases where there is an IVF or where there are multiple pregnancies. Anything can be done? The most important message is prevention is the best for venous thromboembolism. And this is what has been quoted from Agency for Healthcare Research and Quality, whether it's JCIA or it's a National Quality Forum. And they have, each one have their own quote. If we take the first quote, which comes from Agency for Healthcare Research Quality, and what they say, VT is the #1 patient safety practice for hospitalized patients. So again, most important message. Joint Commission, again, the same message. All hospitalized patients should have prophylaxis for VTA and documented why not VTE prophylaxis was given. So again, if you don't give, you need to write that explanation. Then comes, what about National Quality Forum for Safe Practices? They again say routine evaluation for all patients which get hospitalized for the risk of VTE and the use of appropriate prophylaxis. What is one single message? That is not any patient who comes in, you need to make an assessment. This is applicable not to the obstetric patients, for all patients who are coming for any reasons to the hospital. So the prevention, the most important safety practice in the hospital is the prevention, is the VTE assessment, and we need to recognize that it's a patient safety issue. And VTE prevention should be fully integrated into the hospital systems and processes. The trigger for VTE prevention is the assessment of the risk. And when you identify the assessment risk, you did appropriate risk assessment, you need to give the treatment for the prevention, and that can be as per the clinical guideline of your area. This is again coming from the Council on Patient Safety and what they call it as Patient Safety Bundle. It again has 4 elements to be ready. That means we should have a standard thromboembolism risk assessments, which you can integrate in the electronic systems nowadays. Then you need to have the recognition and prevention. That means we need to apply these standard tools. We need to educate our staff. We need to educate our patients. Then you need to have a response that each individualized unit should have, like what could be the mechanism for the management, which could be either thromboprophylaxis, which could be in the form of mechanical, or it could be, which is the best, is the prophylactic or therapeutic pharmacological anticoagulants. And again, there should be a reporting system to see if how well we are doing it. If there is anything, did we follow the systems, or is there any problem, or is there lack of awareness, and what could have been done better in these situations. Risk assessment has to be done on 4, which will be covered by my other speakers before me. And my role will be, don't forget the post-delivery, or if a patient gets readmitted for any reasons after delivery. So awareness of the risk factors and need for screening can go a long way to prevent harm to our mothers. And VTE risk is a dynamic and may change during pregnancy, during delivery, or postpartum. So that's why you need to do the repeated assessments, especially if undergoes any surgery, any trauma, any infections, any readmissions. We need to make the changes in the assessment. Now, this is another very interesting question. Should women with previous episodes of VTE receive anti-thrombotic prophylaxis? This is one of the studies which has been done on the patients who had a previous VTE. More than 1,100 women, and 88 of them became pregnant and who received anti-thrombotic prophylaxis. Again, important thing, how many episodes or VTE recurrence was in them? 9 of them had antenatal and 10 of them developed postnatal. Again, postnatal being the most risk area than the antenatal period. The rate of recurrence did differ. If it was unprovoked, means during pregnancy or during OCPs patient was taking, then it was 7.5%, whereas in the provoked, where the patient developed VTE after surgery or they were immobilized for trauma or any reasons, there was no episode in these mothers. And the rate of recurrence postnatally was higher in both the groups, whether it was an unprovoked or it was 3.9 fold higher than the patients who had unprovoked VTE. So the question comes then, that means we should be giving prophylaxis to all mothers who have previous VTE, which is unprovoked. What about should women with previous episode receive antithrombotic, low risk inherited? They have thrombophilia. I think thrombophilia is, again, we need to define what's a high risk thrombophilia and what's a low-risk thrombophilia, because it makes a difference. And I think my previous speaker has covered this thrombophilia in detail. But I would say that if it's a patient has a high-risk thrombophilia, they are high risk for developing thromboembolism in comparison to the women who are low-risk thrombophilia. And it applies both to the antenatal and to the postnatal period. But whereas antenatally, there was no statistical significant increase in the risk of recurrence, but postnatally, carriers of factor V laden mutation had a risk of about 14.2%, and if it is a factor V laden mutation and they had unprovoked VTE, the risk goes as high as 30%, which is 6.8% higher than the women without thrombophilia and VTE. So again, another important message: if a patient has thrombophilia and she has previous unprovoked VTE, she's extremely high risk for developing VTE, especially in the postnatal period. So if I have to define which one is a high-risk thrombophilias, this is one of the good studies which has meta-analysis of 36 studies, and what they looked into thrombophilias and the risk of first venous thrombosis. So if you have a patient which is anti-thrombin deficiency, these are extremely high-risk patients for developing venous thromboembolism. Protein C, protein S, yes, they are high risk, but they are not as high risk as patients with anti-thrombin deficiency. But if a patient has a homozygous factor V laden mutation, homozygous prothrombin gene mutation, they are high risk. Or if a patient has heterozygous, they have double mutations, that means they have heterozygous factor V laden mutation and they are heterozygous factor V laden mutation and prothrombin gene mutation, they again become high risk for developing postpartum thromboembolism. So variable risk of VTE is because you need to take into consideration how low the thrombin deficiency is. If it's less than 50%, the patient is very high risk for developing venous thromboembolism. Does pregnancy weight gain have any influence on the postpartum risk of venous thrombosis? Very good study, very small numbers, but still an important message that BMI more than 30, the risk of developing venous thromboembolism is about 4-fold greater risk in comparison to a patient who is more than 40 BMI. The risk is much higher than the women who are less than 30 or who are less than 40 kilogram per square meter BMI. Again, it has been shown that there is an increased risk of developing postpartum thromboembolism in women whose weight gain was more than 22 kilograms during pregnancy, which is about 1.5-fold higher than the patients whose weight gain was less than 22 kilos. In the diagnosis, I think clinical presentation, we all know, is unreliable. But what is important, if a patient, there is one rule of 3 objective variables, which is called left. And this is highly predictive of DVT in pregnancy. But this left applies mainly to the first trimester. The L stands for symptoms in the leg. That means patient comes with a leg pain. And then you do the measurements of the length, comparison of the calf circumference on the two sides. If you find the difference of more than 2 centimeters, it's again an important parameter. And the third one, which is if it happens in the first trimester. So what has been found that if a patient has 0 of these variables, the risk of having deep vein thrombosis is extremely low. If they have 1 variable, the risk is about 16.4. But if they have 2 or 3 variables, the risk can be almost more than 58%, almost 60% of the women will have possibility of having DVT. And what's the gold standard for diagnosis? We know gold standard is venography, but we don't do because of we have better modalities available, and the best modality for doing this is compression ultrasonography. And this is what you find. You find a non-compressible lumen in the transverse plane, you find echogenic material in the venous lumen, and you find loss of normal phase of flow pattern in the veins, and the sensitivity and specificity is extremely high. If you want to do, you can do magnetic resonance venography, but long-term effects of this are not well known and relatively contraindicated in pregnant population. The second one, if somebody comes with these symptoms like shortness of breath, chest pain, cough with hemoptysis, cough pain, dizziness, or maternal collapse, even some may present just to the emergency with the just sudden collapse, and that can happen even up to 15%. Clinical diagnosis of pulmonary embolism in pregnancy is difficult because the physiological symptoms of pregnancy can overlap with the symptoms of venous thromboembolism. And this is a simple algorithm which can be followed in patients. If a patient comes very unstable and you do an ABG, ECG, and X-ray, and you immediately go and do an echo, if you find that the suggestion of massive pulmonary embolism, straight away you can consider either thrombolysis or thrombolectomy or low molecular weight heparin. If your patient is stable, then you can give them anticoagulation, do the Dopplers. If the Doppler are positive, carry on. If they are negative, then you can do either a VQ scan or you can do CTPA, again knowing the risk benefits, which will be again having covered previously. I think I want to take some words from this EMBRACE report. That is, the recommendations is, this is about the SARS infections, which has presently the era where there is common problem is this now towards the what happened recently, and still we are in that phase, is the COVID-19 infection. And these are the EMBRACE recommendations, which was published in May 2020. And this is about infection with SARS-CoV should be considered as a risk factor for development of venous thromboembolism. If anybody gets admitted to the hospital with suspected COVID-19, we should give them all prophylactic low molecular weight heparin. If they are symptomatic or they have associated complications, you need to discuss in a multidisciplinary team, and you may give the appropriate dose, which could be either intermediate low molecular weight heparin or a full therapeutic dose. Hospitalized patients should receive thromboprophylaxis for 10 days following when they get discharged after being well. Readmission or readmitted confirmed or suspected COVID-19 within 6 weeks postpartum, they should receive thromboprophylaxis for the duration of their admission and also 10 days after discharge. And these are very strong recommendations, and these are mainly covering to the COVID-19. So what is the long-term sequelae of these patients? If a patient develops VTE, they do have a long-term, significant short-term and long-term morbidity. Not only so, there are financial consequences of having the long-term morbidities. As we all know, obstetric pulmonary embolism case mortality rate is about 3%, but 20 to 25% of all VT events which happen in pregnancy are pulmonary embolism. For each pulmonary embolism, there are about 132 VT events. That means if we take overall, there should be at least, if you have one maternal death, for that there are 132 VTE events. And for these 132, they can have long-term health consequences, which could be in the form of chronic post-thrombotic syndrome, or it could be chronic thromboembolic pulmonary hypertension after pulmonary embolism. This has a significant impact. So what's important is the effective prevention, if diagnosed, treated appropriately, and that's what's most important, is the prevention. This is a very long-term studies over the 16 years of period. What they did, the commonest symptoms in these patients where they will complain is the swelling, pain in the leg, discomfort, eczema, varices. The worst thing is the ulcers of the affected limb. And what this leads to, reduced quality of life, and it has a lot of financial implications. If treatment requires the cause, they may lose their jobs, and that also has a lot of implication in the finances. Now, about 20 to 50% of the patient will develop some degree of post-thrombotic syndrome, but severe post-thrombotic syndrome can happen in up to 10% of the patients who develop venous thromboembolism, especially during pregnancy. So what's important, these women should be advised to use the compression stockings, which have to be appropriately measured and have an appropriate compressions. And they have to be wearing it out at least for a minimum of 2 years, and it may reduce the frequency by about 50%. There's a scale, which is called Villalta scale, which can be used to assess the severity of post-thrombotic syndrome. The symptoms are what I said before, is the pain, cramps, heaviness, paresthesia, itching in the leg, and then you have the clinical signs, which include simple like pretibial edema, skin induration,
when you click on that,
venous ectasia, or pain on compression. And the score extends up to 33, and each score can be given a number from 0 if no, and to 3, which means severe. And if you get a score of 5, that means the patient has some post-thrombotic syndrome. But if the score goes beyond 15 points, or a patient has 1 only, that is the presence of venous ulcers, this defines it as a post-thrombotic syndrome. In conclusion of this study was that post-thrombotic syndrome is common, and its long-term complication after pregnancy-related deep vein thrombosis and proximal postnatal thrombosis and smoking, higher age, were independent risk factors for development of post-thrombotic syndrome. So again, we know most of the thrombi which happen during pregnancy are proximal. It may be either in the iliofemoral or even above popliteal. The other one, which is a common problem, is the chronic thromboembolic pulmonary hypertension. It's rare. It leads to exercise limitation on cardiopulmonary exercise testing. 1 year in 50% of the population it can be seen. And it negatively, again, influences the quality of the life. And again, it leads to impaired quality life across, which could be physical, social, psychological, or it could be includes the mental health, and it can even have an effect on the neonatal outcomes because the breastfeeding duration and even have impact on the infants. What are the medications which can be used? Low molecular weight heparin comes as the best medications which can be given, and it is predictable and has a reliable pharmacokinetic functions and can be given in a daily dosing rather than having a divided doses. It has a lower risk of developing bleeding, heparin-induced thrombocytopenia, osteoporosis, and even the allergic reaction. The risks are extremely low. There are studies which have looked into how much is the risk of developing all these risks. The risk is extremely low in comparison to the unfractionated heparin. If heparin is contraindicated for any reasons, there are some studies where danaproids or fondaparinux has been used, but we should understand it has a long half-life. If you need to do surgeries or anything in a quicker duration, there may be a risk of hemorrhages in those patients. The medications which still need to be avoided during pregnancy are oral direct thrombins, that's the dabigatran, and anti-10A inhibitors like rivaroxaban, apixaban, and they are not recommended during pregnancy. And same applies to the aspirin. There is no role of using it as a treatment for thromboprophylaxis in pregnancy as such. There's no studies on it. What about breastfeeding? Low molecular weight heparin, warfarin, danaproids can be given during pregnancy. Alternative anticoagulant for any reasons, if cannot be given, fondaparinux and oral direct thrombin and factor Xa inhibitors can be used during breastfeeding if there is no alternative available. Low-dose aspirin can be used for vascular indications and safe to continue with the breastfeeding. I just want to say a word about thrombolysis in pregnancy. Yes, it can be used. There are 2 ways it can be given. One is a systemic and another one is a catheter-directed. Systemic indications are mainly iliofemoral, and systemic is you need to have the cannulation, you have a high risk of bleeding, but is less effective in occlusive thrombosis. If you have an occlusive thrombosis, you have to do catheter-driven thrombolysis, but is a risk associated with the risk of radiation, and there is but low risk of bleeding, but it's more effective in patients who have occlusive thrombosis. Role of IVC in filters in pregnancy is very limited data. Indications is only in patients who, in spite of being on anticoagulation, develop deep vein thrombosis. Decision to use them needs to be done after a multidisciplinary team discussions, and because it is very difficult to retrieve them because they can undergo angulations or distortion of the devices during pregnancy, and even the thrombosis of the filters has been reported during pregnancy. This is what is a neglected part of the story, and that's patient experience of pregnancy-related thrombosis. And it was a very good article which was published in Thrombosis Journal and was carried out by the King's College Hospital. What they looked into that, what does it have negative impact on the patients? And the patients, which they answered the questionnaire, the first thing they said about was the challenge in established diagnosis. They had repeated visits to the hospital. They were coming to the hospital and sent back because the symptoms was always labeled. They came with the leg pains, was told this is normal in pregnancy, slight breathlessness, very normal in pregnancy. As we know, there is a physiological overlap with the symptoms. Then again, the diagnosis, and there was no clear communication regarding the diagnosis, exposure to radiations, and then again to cope with the treatment, which was the daily injections, which were painful as well. And then what was the fear was the what about future of them if they get pregnant or without pregnancy. So as a clinician, it's our role to enhance their experience, and how we can do this by improving the communication and information. That means if a patient is having symptoms, to listen to them and to do the appropriate investigation. And if we do any of these diagnostic investigation, speak about the safety of these diagnostic procedures and what are the treatment pathways. And again, to have an awareness about this condition among the patients, like if a patient is a very high BMI 40 or patients with 30 BMI, but she has other risk factors, to explain to them when they should report, what are the symptoms with the VTE, so that they can report in time. These are some of the things which I want to say as a take-home messages. Prevention and diagnosis and treatment should be a priority for all health services. Evidence that doctors and midwives presently are finding some of these scoring systems very difficult to apply in practice. There is a need for development of simpler tools for assessment, which can be very reproducible. And again, one of the best way is to do the electronic VTE risk scores, and they will reduce the variation in assessment as well as will escalate to give the appropriate treatment. We should be auditing not only whether the assessment was carried out or not, but also to see whether it's appropriately calculated. And again, if it is calculated, did the patient receive appropriate management? Women diagnosed with pregnancy-associated VTE must be managed as multidisciplinary and collaboration if needed to write the full care plan during pregnancy, in labor, and in the postpartum period. Suspected DVT, all these patients must undergo diagnostic imaging. I want to repeat, any patient where you have a suspicion of deep vein thrombosis, these patients must undergo diagnostic imaging. It's extremely safe. And perfusion scintigraphy or CTPA or venography all have 100% sensitivity and can be used safely during pregnancy. Any patient who is BMI more than 40, irrespective of the mode of delivery, should be given thromboprophylaxis. And again, if you are giving a prescription, for example, for the 6 weeks, it should be given as a whole to the patient so that the patient doesn't need to come back for another prescription. If a patient has a history of venous thromboembolism, or she has a potent thrombophilia, which I mean antithrombin, homozygous factor V Leiden, or prothrombin gene mutation, or she has a heterozygous for prothrombin gene mutation, or she has a heterozygous for combination of these two together, factor V Leiden mutation and prothrombin gene mutation, they should be considered for thromboprophylaxis, especially in the postnatal period. Please keep watch for these three important studies, which may be published either 2021 or later. And one is called PARTUM trial, which is postpartum aspirin to reduce thromboembolism undue morbidity, and high-low study, which is about comparing the 2 doses of low molecular weight heparin for the prevention of pregnancy-associated recurrent venous thromboembolism. And the third study is a lead study, which is to safely ruling out deep vein thrombosis in pregnancy with left clinical decision rule, but adding to it D-dimers. There's another study which recently got published on this D-dimers. There's a debate whether D-dimers have to be used or not, but there are studies going on, and maybe there will be some cutoff levels and the others not alone of its own with other symptoms or with other modalities of imaging, which may be taken into consideration. So watch for these, and hopefully that will help to find out. These are some references which I can, if there is a time at the after finishing, I'm happy to discuss some of the debates about different guidelines, because there is so much difference in different guidelines. And I want to stop here. Thank you very much about listening to me, and I'm happy to answer any questions. Thank you.
Thanks a lot, Dr. Salima Mani. It was very informative presentation, full of tips, full of guidelines, full of references, and we will be now receiving the questions. More questions, please. Try to type as fast as you can so that we can share with the speakers your queries. Now, most of the audience did not mention whether they prefer any speaker or they wanted their questions to be directed to a specific speaker. So if we start with Dr. Salima Wani, one question says that if the patient gets readmitted after 10 days of cesarean section with wound infection, she should receive low molecular weight for further 10 days or extended to 6 weeks?
Okay, depends upon how much is the wound infection. If it's a superficial wound infection, I don't think, first of all, we should be admitting her. We can give her thromboprophylaxis because we want. But if it's the deep infection, which is called cavity on walls, like peritoneal cavity or anything, then in that situation, I would say yes. As long as she's unwell, you can give it up to 4 weeks or up to 6 weeks. It doesn't matter that way, because it's very important.
Okay. Dr. Amala, one question is that, I'm sorry for that, but it's repeated questions. Maybe it went through, it has been mentioned in the live presentations, but it's repeated questions. How to consider this patient as high-risk thrombophilia if they have the low-risk thrombophilia? Like, which risk factors are more important, very important to add to it to consider it high risk? Suppose she is protein S deficiency or heterozygous factor V. When to consider it, or heterozygous for prothrombin gene mutation. So when to consider it high risk? Which other risk factors can be added to consider it now as a high risk, to start from the beginning the thromboprophylaxis? Dr. Amala? Maybe.
Yes, hi. Yes, no, I'm here.
Yeah.
So if you were to consider high risk factors for thrombophilia, especially with antiphospholipid antibody syndrome, we investigate the patient for beta-2 glycoprotein. We investigate the patient for protein C, protein S, which are anyways depleted during pregnancy. But if excessive depletion or presence of 3 or more factors, then we consider them to be high risk thrombophilia. If we have a patient with antiphospholipid or cardiolipin antibody positive at 2 separate occasions, 4 to 6 weeks apart, then they are considered as high-risk thrombophilia. If there is associated protein C and protein S deficiency, then definitely low molecular weight prophylaxis has to be started from the first trimester onwards and has to be continued up to 6 weeks postpartum.
Okay. Dr. Bashir, there is one question. Yes, Dr. Salima. Yes.
I think what is thrombophilia? One is the acquired thrombophilia and one is the congenital thrombophilia.
Congenital, yeah, true.
Because if it's a congenital thrombophilia, the high risk one comes antithrombin 3, homozygous factor V lesion, homozygous prothrombin gene mutation, and heterozygous factor V mutation and prothrombin gene mutation. I think these has to be taken into. I'm lucky nobody asked at least for MTHFR. Please don't include it as a thrombophilia.
No, there is a question on MTFHR. It is not included as thrombophilia, but I unfortunately answered that question, but it's not considered as thrombophilia, MTFHR mutations. Yeah.
There is one question, if Dr. Bashir, can you answer it? It says that RCOG says whoever needs antenatal thrombophylaxis also needs 6 weeks postpartum. most of UAE community fulfill the basic score, like age, parity, BMI. Is 6 weeks thromboprophylaxis really needed for 6 weeks in this group of patients? If the patient is educated, isn't that TID stocking and hydration mobilization will do the job, and instead of giving the low molecular weight for heparin for 6 weeks, like?
For you, Dr. Bashir.
Yes, I just missed the first part of the question. Can you repeat that, Dr. Tariq, please?
The question says that RCOG says whoever needs antenatal thromboprophylaxis also needs 6 weeks postpartum. But most of UAE community patients fulfill the basic score of like age, parity, BMI. Is 6 weeks thromboprophylaxis really needed for 6 weeks for this group? Isn't that
No.
the TID stocking and hydration mobilization will not do the job?
No. I agree with you that not all patients need 6 weeks postnatal prophylaxis. And even the RCOG didn't say that for all patients. There is, as they are categorized, high risk, intermediate risk, and low risk. The high risk, those one was venous thromboembolism or acquired or congenital thrombophilia. Those are the ones who need 6 weeks postnatally. But the others, they need only, if a cesarean section or normal delivery, 10 days. Now we give them for 10 days. The others, only the high-risk one groups who need more than that. But we give them the advice that even after 10 days, they are still at a risk for, of course, lower than the others. And that's why hydration, mobilization is very important.
Okay, Dr. Salima Wani, there is one more question. If the patient has heterozygous factor V Leiden deficiency and no previous history of VTE, and is it that low-risk thrombophilia? Should we consider her for prophylactic thromboembolism or treatment of thromboprophylaxis during pregnancy?
The answer is no, big no.
Yes.
Because heterozygous factor for either of them is not high risk unless she has a previous risk of having, previously she had a VTE. Other than that, no, the answer is big no, because these are low-risk thrombophilias.
If the patient is high risk for VTE, should we start as heartbeat positive or from 12 weeks?
Okay, it's not from 12 weeks. If a patient is high risk, you don't wait for heartbeat. You start as soon as you confirm she's pregnant, because thrombosis risk increases the moment you are pregnant. So you start it as soon as you are positive.
Okay, that's great. About miscarriage. If it is labor, 6 weeks. If it is miscarriage, for how long?
Sorry? In miscarriage, 10 days.
How many days?
10 days. Same, 10 days. 10 days.
10 days. And if it is needed for 6 weeks post-delivery, if it is miscarriage, then for how long?
You don't need after miscarriage. If you mean that if she was pregnant and then she miscarried and she's a high-risk VTE, then you can extend up to 6. You see, that's why I was saying in the end of my lecture, it depends the guideline you follow. If you go for American College guideline, or you go to Canadian Society and the guideline, or you go the recent one, which is American Society of Hematology guideline, you're confused because all of these guidelines give you different, assessment. The only thing where we are in agreement, that's only one thing. That's patient with unprovoked VTE. And these are the only ones where we have consistency. Rest, if you ask me any of the parameters, I would say there is so much difference. You don't know which one. So I think if you are following the RCOG guideline, then you are fine. You can use 6 weeks. But if you are following American guidelines, there is nothing like that. Like, for example, for all cesarean sections, most of us give Thromboprophylaxis, whereas American guideline doesn't agree. American Society guideline doesn't agree. But if you are following an RCOG guideline, you are absolutely fine. You are not losing anything if you are giving for 10 days prophylaxis.
But I think, if I may comment, I think we are following the RCOG guidelines, and we stick with what the RCOG tell us really, because if you start using different guidelines, then you are confused and you don't know what is the system in your hospital. I think every hospital should stick to one guidelines and follow it.
Yes. Dr. Amala, thank you.
Yes.
Dr. Amala, there is one
Can I
question.
add something?
Yes.
To this? I want to add to this particular question. What Professor Bashir Taha says is right, that RCOG has very clear-cut delineation about how many factors and what to start at what level. I think it is much more organized and easier to follow by everybody, including the paramedical staff, while taking history or taking vitals for the patient. So it's a far more easier guideline to follow, in my opinion.
Dr. Amra, there is one question. Thanks a lot for your wonderful presentation. Is there any relation with blood group O with higher level of von Willebrand factor and thereby increasing the risk of DVT? Is there any relation?
Von Willebrand factor, are you talking about deficiency of von Willebrand factor?
Must be the question, von Willebrand deficiency.
What exactly is the question? Because deficiency of von Willebrand
factor
will cause bleeding disorders.
Yeah, bleeding disorders.
It will not cause thrombosis.
Blood group O. Is it at higher risk of having DVT? Is there any studies regarding
There is no correlation of any particular blood group in any of the guidelines mentioned. There is no correlation or no predisposition that if you belong to one particular blood group or one particular RH type that you have increased risk of developing DVT. You have to understand that the vascular thromboembolism is rare. RCOG categorizes it as a very rare phenomena where 4 to 16 in 1,000 pregnancies get diagnosed with VTE, out of which 30% of these VTEs are pulmonary embolisms. So it is generally very rare, and there is no predisposition of any kind to any blood group or any RH factor with vascular thromboembolism.
Okay, thanks a lot. Dr. Salima Wani, regarding the BMI, which BMI to be considered? Booking BMI or the current BMI? Your voice, Doctora. Unmute, please.
Okay, it is booking BMI, basically. But there are now studies which are saying about the weight gain in pregnancy. If somebody has undue weight gain during pregnancy, like somebody has BMI of at booking about 26, for example, and she gains 22 kilos, and that's a risk factor that has to be taken. Like undue weight gain is an additional risk factor. And I quoted the study even on that because this is a very important question which comes up all the time. Her BMI was at booking 22, and when you reach to the delivery, she's 35. So again, it's important that she doesn't have an undue weight gain. Otherwise, BMI should be taken as
which one you consider? You, Dr. Salima, yourself. Which one you consider?
Okay. If you ask me, I'm going to give postnatal thromboprophylaxis. I consider the weight at that day when I am going to operate on that particular patient.
More logic.
Because I have to feel this weight gain take into consideration. Yes.
I agree with her.
Yes,
I agree with Dr. Salima Wani. I think this is the recommendation to take the present weight, not at booking. Yeah, because things change in pregnancy.
The question, again, they wanted to clear it. If the patient on thromboprophylaxis during pregnancy, she should continue thromboprophylaxis postpartum for 6 weeks. Suppose she is not from the beginning, only from 28 weeks only. Still, she has to continue for 6 weeks?
No, the answer is no. 10 days.
No.
Only 10 days.
10 days.
Yes.
Dr. Amala, when to do the thrombophilia screen for a patient who develops postnatal unprovoked DVT?
Immediately. As soon as the patient presents with DVT, I think it should be one of the primary investigations to rule out any kind of underlying thrombophilia. If a history is not known, I think as soon as possible.
even if she is on Clexane, or even if she is on anticoagulant?
No. So if the patient comes and she's on anticoagulant and you're suspecting thrombophilia, Royal College recommends that for a period of 48 to 72 hours, you halt the low molecular weight heparin therapy, collect your bloods after 48 hours for thrombophilia screening, and after the results are obtained, then you decide whether you need to continue the screening or the prophylaxis or not.
I would disagree on that a little bit, because if a patient is already on anticoagulant, the value of thrombophilia screen is nothing, because you don't gain anything. You have to continue with your thromboprophylaxis. Rather, you have to change from thromboprophylaxis to therapeutic dosages now, because she developed VTE. I will do it after postnatally, when she has covered the period of DVT, has acute DVT management, and then I will go and do the investigations, because that's not going to change my management. I will only go from prophylactic to the therapeutic. Develops DVT during pregnancy.
There is one patient who had developed pulmonary embolism 5 days post delivery, and she was tachypneic, diagnosed as pulmonary embolism, and put on therapeutic Clexane. And then for how long she'll be receiving the therapeutic dose of anticoagulant, and when to do the thrombophilia, so that she will know herself if she is high risk to be on a lifelong anticoagulant or not. Is it safe to stop it for 6 weeks and then do the thrombophilia screen after 6 weeks of stopping anticoagulation, or to do it on spot and to find out whether she is high risk, to advise for lifelong anticoagulation, how to manage?
MDT.
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 Yeah, correct. I tell you my part, and then I will ask the obstetrician to complete. My part is that there are, first the patient comes first, I think. We should treat the patient. Yeah, there are some thrombophilias which we can do while the patient is under anticoagulant treatment, and there are some, of course, you have to stop and then wait.
Protein S and protein C.
So yes, just like protein S and C and so on, antithrombin. But those ones you can do, just go ahead and do them while you are giving her therapeutic dose, and make sure that the patient is safe. Anything you want to add, Amelia or Wani?
I just want to add one thing. If I have a patient with PE, I'm least bothered for about her thrombophilia screen at present. I have to cover her acute phase, which is 3 months. Let me continue with her 3 months treatment, and then I will go ahead and do the what next, because it's not important at this time to see whether she is thrombotic, thrombophilia or not, because that's not going to change my management. I want to give her this time treatment, which is the acute phase treatment. After the acute phase is, that's what we do, Dr. Bashir. We don't bother with acute phase. We continue with because P is more risky than doing thrombophilia screen. Thrombophilia screen is not going to add you anything much. What is going to add is the management.
Yeah, and I think sometimes even for 6 months, if she is a big PE, you want to continue really for 6 months, not only 3 months.
Yes. So to start on,
but ultimately, it all depends upon the recommendations of a multidisciplinary team. Please try not to be a hero yourself, your colleagues. Please involve your hematologist, immunologist, whatever you feel is right, and get their recommendations and then institute it for the patient. Because after 6 weeks are over, she technically becomes their patient. So she needs to follow up at a hematology clinic or whoever has been treating her then, because the 4th trimester, as said by American College ACOG guidelines, gets over at 6 weeks postpartum. So MDT is very important.
So
I can't agree more with you, Amela.
Okay. If the patient, Dr. Bashir, this is a question for you. If a patient develops hematoma PPH, post-traumatic PPH, should the heparin be stopped and use pneumatic compressions only?
He's not an obstetrician, poor man.
Dr. Salim Awani, because they mentioned
Well,
his name.
after all these years with obstetricians, then I can answer that, I think. But you are free to add anything that Dr. Wani or Dr. Imela. Yeah, I think I will multidisciplinary. I'll ask my obstetrician, what about the hematoma? Is she going to intervene, or is it going to be a conservative management? And how big is the hematoma? Yeah, I think I will. If it is on a prophylactic dose and she is immobile, probably I will continue and watch her for any bleeding tendency or that hematoma increases. But otherwise, I will ask my obstetrician just to have a look and see how much is the anticoagulant will contribute to that. I don't think in most of the cases we will stop the heparin and see the judgment of the obstetrician whether they're going to intervene or it's for conservative management.
I would take it other way around. In case if you have a patient who has a postpartum hemorrhage, in that patient, I hold on only for, you have to be very careful of stopping thromboprophylaxis in patients who bleed, because they are additional risk factor to them now. And especially if you have given the transfusion to them, you have added one more risk factor to them. I have to be really careful not to give them. So I would give them the pneumatic compression, maybe 4 to 5 hours. If it's very stable, I will go ahead with the thromboprophylaxis in them. That's how I do in the high-risk patients.
If one more question, if the patient is on thromboprophylaxis anticoagulation and she is for elective LSCS, when to stop the molecular weight heparin?
12 hours before, if she's going for spinal. 12 hours. If it's prophylactic, 12 hours. If therapeutic, 24 hours.
And I think the anesthetist will let you know when he wants to stop and when it wants to stop.
But the recommendations are 12. Post-operative, post-spinal, post-epidural, 12 hours post. Actually, recommendations say 8 hours, but in our group, we follow 12 hours. So after 12 hours post-surgery, we resume it 12 hours post-surgery.
Yeah, we do the same, Amila.
Yes.
Do you recommend thromboprophylaxis for 3 abortions?
No, big no.
No.
Big no.
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 When can we do the acquired thrombophilia?
3 months after delivery or 3 months after the miscarriage, if you really want to make sure that you are doing appropriate testing. Before it was 6 weeks, and now it has changed up to 3 months, because you want the full recovery of the pregnancy changes before you go for the next test.
Correct.
Okay. Is there any chance? What are the chances of bleeding when using prophylactic purpose? What is the chances of bleeding? No bleeding at all, or high prophylactic dose, or there is no bleeding at all?
Well, one of the things which I've been a surgeon for a pretty long time, I think if you do a good hemostasis at the time of surgery, your risk of bleeding is minimal.
Yep.
If you are not good in, hemostizing well, there is a report of 2.5% risk of having the hematoma formations. But I would say attention to hemostasis at the time of surgery is the answer. I don't think we see so many hematomas of 2.5%, which is huge numbers. I think we don't see that numbers in practice.
Yes.
Can I add to that?
Yes, please.
I think people are afraid of bleeding, but I think they should know that pulmonary embolism can kill a patient, where bleeding is really, our surgeons are very good in stopping the bleeding and recognizing it. So I think before you decide to stop the anticoagulant, as Dr. Wani mentioned, you have to be sure of the hemostasis. But I've seen for many, many years, no bleeding under prophylactic dose. If she's on therapeutic dose, that is another thing. But prophylactic dose, it's very rare that you have bleeding after giving prophylactic dose.
I have even operated patients who have been thrombolized. You remember, Dr. Bashir, the valve thrombosis. She was on full thrombolysis, and I had to operate on that patient. Believe me, there was no bleeding. So I think sometimes we over-exaggerate bleeding.
Yes. Regarding COVID pneumonia patient on high therapeutic dose of anticoagulation and they go for cesarean, how to manage them with clean surgery post-operative?
Okay. Should I answer?
Yes, please. Yes, please. Please. You're the most qualified to answer that, doctor.
Yes.
She has operated on somebody on full anticoagulant.
Full. I have operated on why two? I have operated on 3 patients on full therapeutic doses. In the sense, like they have just given therapeutic dose and 2 hours I had to operate. I think what is important at the end of the day is attention to hemostasis. They don't bleed extra. Rather, you should remember in COVID, you have thrombosis.
Yep.
They are already so hypercoagulable. Their fibrinogens are 7-8 grams, so high fibrinogens. So the risk of bleeding is, they have on one side thrombolysis, on another side they have the coagulation. But believe me, none of them bleeds. Don't worry. Go ahead and operate.
Okay, that's interesting. Very nice. Would you like to add any points from your experience or take-home message to our audience?
Well, I would say the only thing, if you want to do, prevent. And the prevention is by doing appropriate assessments and doing the appropriate management. If you don't know, pick up a phone, call your friend that I have a patient with this, what should I do? And I always, whenever I have a doubt, I don't find it below me to call any of my colleagues, or most of the times regarding cases which are medical disorders, to my obstetric medicine team, Dr. Bashir, Dr. Nagina, or their colleagues, because it's question of safety of a particular patient. So don't have this obstruction or thinking that I'm the best, I know everything, I can do everything. I think ask someone who is an expert. If we have, as when we do a clinic and we find somebody a very high risk, we don't mind to ask a subspecialist, can you help us in this situation? We are doing this and we have done this, but we are not reaching anywhere. What should we do next? It's no harm in asking. So I think I would give a message, if you don't know, pick up a phone, call your friend.
Any recent interesting case you would like to share with us?
Oh, lots.
Many.
What do you want to know? COVID, not COVID, what do you want to know? I think let me interesting case I'll tell you about. We had a patient who has basically had thrombosis of the valve. Dr. Bashir, you are very well aware of the patient. This patient had, old type of valves, not the biological. So then she developed a thrombosis in the valve. When she had a thrombosis of the valve, there was hardly any flow through the mitral at all. It was so thrombosed. So the choice was what to do. So interesting was that they said, can we give thrombolysis? So we had an MDT, if you remember, Dr. Bashir, myself, hematologist, and Mafraq Hospital doctors, and decided, no, let's go ahead with thrombolysis. So she was given 1 thrombolysis. After a few weeks, she again thrombosed and gave another thrombolysis. By then, she had reached 28 weeks. And then we had to decide, because she was about to get the 3rd thrombosis on this valve, it was not dissolving. So we had a big MDT in which we had cardiac surgeon. You remember Dr. Bashir? Cardiac surgeon, cardiologist, myself, Dr. Bashir, anesthesiologist, cardiac anesthetist, and we were whole team ready. And what I was asked, when you do the surgery, you take this baby out, do the hysterectomy at the same time. I said, I'm not going to do hysterectomy on a patient on this. This is interesting when you have an MDT. What happens? We had whole team on our side. No, we will not do hysterectomy. we'll do cesarean section, take the baby out. At the same setting, you replace the valve. I had a very senior doctor as well, consultant with me. So we were operating, two of us. And once we delivered the baby, and the moment we delivered, almost this whole valve got thrombosed during that process. There was hardly any flow. And what happened, the moment I closed the skin, they replaced the valve of the heart. And this was all possible once you have a MDT.
MDT.
That was, and whole team was there. We had whole team. We did the surgery in cardiac theater. We had a whole team. And that's the first time when I saw how they drape a patient for cardiac surgery, because I had never seen a cardiac surgery before. So again, and it was an open bypass, open heart surgery, in which they had to keep the patient, you know, blood is like dilute water. And we waited there for 3-4 hours till we see that the patient doesn't start bleeding from the uterus. They were more worried about the uterine bleeding rather than having a problem with the valve replacement. So again, I think it works as a team, as a group. I think, you know, one of the good changes which we learned in the COVID was we had called something in our hospital called COVID team. And in
what
the
is
COVID,
that?
We had Dr. Bashir's team, Dr. Bashir, myself, two more obstetricians, and 3 anesthetists or 4 anesthetists. We called it as a COVID team. Whenever we have a very sick COVID patient, we all will meet. And all the patients which were admitted in the hospital as COVID patients, we would discuss each and every patient and write the plan of management. And the medical, obstetric, everything, anesthesia, all this. I think if Dr. Bashir can add. Dr. Bashir, if you unmute and add to it what we did.
Yeah, sure. I totally agree with you, Dr. Wani, that multidisciplinary team, as Dr. Amel has mentioned several times, that is the way really forward. And I've got a message really to not only to my obstetricians, but also to my physicians or internists. I think it is good really to discuss cases with other people, because I don't expect physicians to know much about pregnancy. Or at the same thing, I don't expect all obstetricians to know much about medical problems in pregnancy.
Yes.
So I think if we work together and if we ask each other, come together and discuss cases together, I think that will be better for the patients and for ourselves. I think we learn a lot from each other, and that is why I think we have very successful clinics and in Cornish Hospital, because we work very close together, not only during COVID time, but in daily basis. And we have combined clinics with specialists from Sheikh Khalifa Medical City on Cleveland. And I think we are trying our best to give the best service to our patients.
Yes.
Do you remember any case of pulmonary embolism that she presented in an atypical presentation?
Oh, so many. Don't ask me. Don't ask me that question. I think we had one patient who
other than chest pain and desaturation.
No. We had a patient, I think she was a post-cesarean section or post-normal delivery, whatever, and she came with the chest symptoms, and as usual with low-grade fever, pleuritic chest pain, but not desaturating or anything. So what happens with that? Can I tell you one thing? So we thought, we gave her antibiotics, but she's not improving. And finally we said we will do CTPA. And what it was pulmonary embolism. And we treated her and she went home.
Oh.
So this is what is it, where you don't know, ask. And we had similar situation. I think what I want to carry on, one lesson to everybody. Please, please, please make sure that when you have a patient who is high risk for DVT, and we have seen a patient who lost while going to the NICU, while walking in NICU, she died. What had happened? You know, when we write the medications in the system, make sure your medication is written throughout how many days and what. Because what happened, they wrote it the antenatal period. That's why there was missing of this medication reconciliation. So they wrote thromboprophylaxis, like whatever, you know, to give the enoxaparin this many for 5 days. And she finished 5 days, which was 3 days after her surgery. On the 4th day, she went to NICU. She collapsed in NICU.
Oh.
So I will say one message: please, please, please make sure you are doing medication reconciliation all the time on all patients when they are in the hospital.
Also, I want to add one thing to this, is that it's very important to maintain a clear line of communication between the nurses that are managing your patients and you. So sometimes, I mean, all of us have adapted to the EMR technology, notes in the EMR. But I probably may be old-fashioned, but I still believe in keeping the patient's file. So my communication with the nurse who's taking care of my patients, I write my handwritten notes to the nurse and give it to her, so she's very clear about what needs to be given at what time. It's very important that the communication be maintained with our helping paramedical staff and nurses, along with the multidisciplinary team, because confusions can lead to catastrophic results on patients.
Yes, you're right. I agree 100%.
We are paperless. That's why we have to go only on the system-based, and that's why
I'm the only one who's sticking onto the paper, actually. In my, I'm the only one who's sticking to a file. But yeah, a file works. I mean, I guess that's how we've been taught to write in files, to write our notes. So it helps us keep in our memory as well. But it also maintains the communication to be very clear between the paramedical staff and us, you know. So it's always good, yeah.
Thank you very much, our lovely expert speakers, Dr. Bashir, Dr. Salima, and Dr. Amala. There is more questions there, but because of the timing, we have to end it here, although the discussion is very, very, very interesting with you people. So thanks a lot. Inshallah, we'll meet again and again and again, more webinar. So thanks a lot, and good night.
Yes,
thank you, everybody, for sharing your...
Thank you. Thank you. Thank you very much.
Thanks.
Where from you go, Dr. Bashir, then finally link?
We would like to announce that the CME will be available in 10 days' time. Please fill out the evaluation form and answer the quiz, the webinar quiz, and you will be getting your certificates after filling the form with CME credits. Thanks a lot again, our audience. We would like to thank also Sanofi for sponsoring the webinar. Thanks, Sanofi.